Good morning, everyone. Happy Monday. Thank you for joining us for today's webinar titled Responding with Compassion, Identifying and Treating Crisis Needs in Our Senior Communities. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel. To use the chat panel to send any questions you may have as you think of them, we will answer questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. For computer audio, click the up arrow next to unmute, then click the switch audio connection panel. Click disconnect, click the up arrow and switch audio connection again, and then click call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option. The access code and event password will be posted in the chat panel momentarily. Please note that you must be connected to the audio of this presentation as well as view it on screen to receive a statement of credit. We are unable to verify your attendance if you are not connected to WebEx via your computer or mobile device. Therefore, phone call only attendees are not eligible for a statement of credit or CEUs. The recording and materials used in today's webinar will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credit earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through FATA. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Completing the post-webinar evaluation is necessary to receive CEUs or to access your statement of credit. Please note that the evaluation will close at the end of the day on Friday, September 26, 2025. At the end of today's webinar, you will have 3 opportunities to complete the evaluation: a link posted in the chat, a follow-up email from WebEx, and an automatic web browser pop-up when I end the webinar. To complete the evaluation, you will first need to register or sign in to your account. Please ensure that your name and email address match the name and email you used to register with WebEx. Information you provide FATA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your license or certification number when you register with our site. If you need assistance with account registration, login information, or accessing the evaluation, fill out a contact form on our website or email training@floridabha.org before September 26, 2025. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a statement of credit if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be reported to CE Broker within the same time frame. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenters and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenters today will be Jennifer Martinez and Briana Kelley. Jennifer became Executive Director of Marion Senior Services in August 2015, where she oversees local, state, and federal programs for older adults, as well as Marion County's paratransit transportation system. Ms. Martinez is an active leader in the community, having served on numerous boards, including the Community Foundation's Nonprofit Business Council, the Association of Fundraising Professionals, the Ocala Women's Network, and the Marion County Sheriff's Advisory Council. She is also a member of the Florida Council on Aging and currently serves as first Vice President of the Florida Association of Service Providers. Her leadership has been widely recognized. She was named a top 40 under 40 professional, received the 2010 Business Advocate of the Year Award for her work on behalf of local nonprofits, and under her direction, Marion Senior Services was honored as Nonprofit of the Year by the Community Foundation in 2023. A longtime Ocala resident, Ms. Martinez earned her degree in hospitality management from the University of Central Florida. Dr. Kelley is a human service counselor with Marion Senior Services, where she connects with the senior community to identify potential client needs, services, and gaps in services, provides geriatric counseling, and educates caregivers on advocacy for their loved ones. Dr. Kelley is committed to educating seniors and caregivers on planning and maintaining a safe, fulfilling, independent lifestyle for as long as possible. Dr. Kelley earned her doctoral degree in human services from Walden University in 2020. She has over 17 years of experience with crisis intervention, mitigation, and research in stressors and coping in emergency services. She has researched 911 processes, planned and presented at local, state, national, and international conferences in the emergency service realm, and been a law enforcement clinical responder, responding with law enforcement to individuals actively in crisis. She also holds a Master of Science in Mental Health Counseling from Walden University and a Bachelor of Arts in Anthropology from the University of Florida. And now I would like to welcome our first presenter, Dr. Kelley. Dr. Kelley, I will turn it over to you.
Good morning. Thank you for letting us visit today and share some insight. Actually, you're going to start us.
Yeah. So good morning, everyone. I'm Jenny Martinez. We're going to get this rolling, and we kind of want to lay out the groundwork first. So the title is Responding with Compassion, Identifying and Treating Crisis Needs in Our Senior Communities. We really have worked hard over the past couple of years in filling in the gaps, not just for our agency alone, but for our community and for the partners that we have working with us. So if we can go to the next slide, Robert, please. The learning objectives for today. We want to understand behavioral health and substance misuse challenges faced by our older adults.
We're going to also look at identifying treatment considerations for providing services for older adults.
Understand our mission at Marion Senior Services and our work in our community.
And identify strategies and challenges in program implementation for older adults. We recognize that we build this in flight, so as we continue to identify, we'll continue to grow and meet needs.
Next slide. Thank you. So who do we focus on? We focus on individuals 65 and older. Marion Senior Services is the lead agency in Marion County for elder affairs, so that also makes us the arm for adult protective services with DCF.
We also looked at statistics, and according to the 2020 census, 1 in 6 Americans were over 65, and they're continuing to grow. They call it the silver tsunami.
Leading to the next bullet point, the estimated population of our senior citizens will reach 88.8 million by 2060. And if you are in the aging network, which I saw a lot of you are in the chat, we have great work stability, right? And a lot of work in front of us. But the baby boomer generation will outnumber any other generation in the world.
So finding creative ways to meet them where they're at and recognizing that there will always be more needs than resources, and recognizing that the average life expectancy beyond 65 is nearly 20 years. Next slide, please. So this is supposed to be popping up, and in the boxes it should say mental health, suicide, cognitive impairment, substance use and misuse, grief, and isolation. Those are just a few of the concerns. But one thing, when we started this, we didn't know what we didn't know. And it's been very insightful, bringing awareness to population that was previously not seen.
Next slide. So mental health is a huge component for us. Up to 25% of adults 65 and older are living with a mental health condition such as anxiety or depression.
And less than 40% of them are receiving treatment. A lot of times what we're finding is that the comorbid dependencies that exist, receiving facilities aren't equipped to handle, like the oxygen or the mobility impairment or the additional fragility of them.
Next slide. Mental health is underdiagnosed in older adults due to symptom overlap with physical illnesses and age-related changes.
And then the stereotyping and stigma about aging lead to different beliefs that it's just normal. And then you end up walking through a system that is kind of difficult and siloed.
And then mental health problems can occur later in life with no prior diagnosis. So they always say it's a part of aging, right? You can go to the next one. Thank you, Robert. Suicide, unfortunately, is one of our growing ones. Older adults account for 22% of suicides.
And older adults are less likely to survive a suicide attempt. We've often found that caregiver burnout, which we'll talk about a little bit later, has been one of the leading causes.
Men age 75 and older have the highest rate of suicide.
Next slide, please. So again, the grief over losing loved ones, losing your independence, the chronic illness, just the additional cost associated with it, different cognitive decline and impairments, the financial troubles, and then loneliness and isolation. We saw a big increase in this when COVID happened.
I'll let you keep going because this is your wheelhouse. Go ahead.
So cognitive impairment, sometimes what appears on the outside isn't always what we see on the inside. And sometimes it may not be caught so easily. So we'll talk later about our high utilizer meetings and some things that we see, but just the mild cognitive impairment to dementia to delirium, there can be similarities and differences amongst them, and sometimes they get mislabeled. We don't really have systems in place to help stabilize when someone is in crisis. So sort of how we would with mental health, like Baker Acts and different involuntary holds, we don't necessarily have that same process when it comes to assistance. And as we know, everywhere wait lists are super long. And then the time that someone spends in each of the progressive stages can differ depending on what's going on with them and their health as well.
Next slide, please. Some of the things that we see with cognitive impairment, and you may see as well, obviously, is memory loss and forgetfulness, misplacing or throwing away items, concentration lapses, impaired judgment or reasoning, making them more vulnerable and susceptible to scams, language and communication difficulties, some personality changes, and disorientation and wandering.
We see many individuals losing homes and all of their retirement because of trusting. And right now we've seen an increase in Bitcoin and people actually driving and meeting others or depositing in these Bitcoin ATM machines. And then they're not able to track them because often the suspects are out of country.
Next slide.
Okay, so let's talk about the substance use and misuse. So we are thankful that in this community, we have core with both the city and the county, so that's covering a lot. But oftentimes we have to be creative in breaking down social barriers to get people to their providers. So one of the biggest social determinants of health has been transportation, and figuring out how to bring the care to the person has been one of the ways that we overcome it. Older adults often have more prescriptions and over-the-counter drugs than other age groups, and sometimes their misunderstanding of how to use it or the education that goes with it can interfere with how it's being taken. Also, how it interferes with other drugs or alcohol. And sometimes they will go to the emergency room and maybe not follow up with their primary care doctor. And if everyone's not on the same page with information sharing, they may be prescribed medications that interact with each other. And then the last bullet point of the drugs and alcohol affecting them differently due to their slower metabolism, and often they don't eat like they previously did, and the weight loss or the weight gain isn't reflected with the medication dosages either. Next slide, please.
So over 1 million adults 65 and older have a substance use disorder.
Alcohol is the most used substance by people 65 and older.
1 in 25 adults are at risk for major prescription drug interactions.
And then the unaffordable medications can also have negative effects. Sometimes they just run out.
Past month marijuana use amongst adults 65 and older was at a rate of 7% in 2023, a 46% increase in 2 years.
Next slide, please. Okay, so grief. This one looks different depending on where we're at, and there's so much diversity in the population 65 and up. There's more diversity in just 65 and older than any other age group or demographic that we work with. So when we look at grief, the most common we look at is death of a partner or a spouse, but also depending on how they're aging, it could be death of their children, their friends, other family members. Pets are a big one. And as we talk a little bit about like our program, pet food has been one of the biggest ways for us to connect with people. And losing your identity as it relates to work or their status, their routines, being able to go out and do even driving can be difficult. And then we see a decline in the health and the loss of the physical abilities. Just we see the use of oxygen and how difficult that can be to even take a bus ride. Next slide, please.
71% of our adults 65 and older have experienced one bereavement in the last 2.5 years. I would say just, within our dining site alone, it's quite often, and you feel the weight of it because they're not just friends, they're family members.
And then approximately 10% of elder adults will develop prolonged grief disorder. We see a lot in the senior communities. Like Jenny said, they are a family inside of a family, so they grieve more because the increase is seen so much more. Research shows that repeated exposure to grief does not make a person more prepared or resilient. In fact, the chronic exposure can weaken their resiliency, and often they won't reach out until they're in crisis. Next slide.
Isolation. Bri kind of touched on this earlier. We saw a huge increase during COVID with isolation, but research shows social isolation can increase the diagnosis of physical and mental health conditions such as high blood pressure, heart disease, obesity, a weakened immune system, anxiety, depression, cognitive decline, Alzheimer's disease, and even death.
During COVID, one of my participants told me that she was trying to live and not waiting to die, and that has really stuck with me a lot, because when we took away their ability to interact, and it wasn't us, the world just shut down, it really was them looking at themselves in the walls for a long time. And that isolation created a physical separation from other people, and you're just alone in your thoughts, which made it very difficult. We're looking at different ways now to combat that, and this is just not a population that likes virtual world or communicating, but even so, that lent to another way to be exploited. So it was a catch-22 on whether to use virtual to connect or not.
And then the last bullet point, someone experiencing chronic loneliness feels threatened and mistrustful of others, making reception to treatment difficult. But then also vulnerable, right? Talking about connecting online. We have so many people who want to feel that love. They are trusting of anyone that gives them that attention and willing to give up their life savings just to have a relationship, which is pretty sad.
It also creates an extra layer to have the conversation from a helper perspective, because then they're caught on whether to believe the person that's giving them the attention and helping with the isolation versus the helper that's there saying, this is not a real person, stop sending them the money.
Mm-hmm.
Next slide.
So a couple numbers, 25% of older adults are isolated, 50% are at risk.
A 2024 poll showed 33% feel lonely.
So the lack of social support increases the chance of elder abuse by 24%. And that sounds kind of low in my opinion, but some treatments, considerations. Next slide, please.
So fostering community for social and emotional support, and actually listening to those that we serve to see what they're looking for, because we can talk at people, but if we stop listening, it's not going to be a one size fits all, and they have a lot to say and be heard.
Comprehensive assessments and screenings. A lot of our stuff have become outdated, so we try to reword them and catch different phrases to make sure we are capturing the true relationship with the client, and then also their social network.
And then access to resources such as transportation and secure housing. I know that just trying to maneuver the system can make me frustrated, so I can imagine how my window of tolerance is probably bigger than a lot of others. And if I'm getting frustrated, someone who maybe is not hearing as well as they used to, or seeing as well as they used to, or not processing as fast as they used to, can become very frustrated. And those that are being asked the questions probably get asked the questions over and over again. So sometimes it can be frustrating for them, and that frustration comes out when they're talking to people. So when we have encounters, I try to remind myself and others that this may be the first time that that person was brave enough to ask that particular question, and we should treat it as such each and every time.
Well-managed medical care and medication regimen. If they have transportation issues, well-managed medical care becomes harder to achieve. And then also, Brian kind of mentioned this earlier with the medication regimen. Personally speaking, I had a health episode a couple weeks ago and went home with 4 prescriptions, and it was hard for me to say at 46. I had to look up how to take all of these medications because they all interacted with each other. And unfortunately, the pharmacy wasn't able to help, but ChatGPT did. I put in exactly what my medications were, when I had to make them, and it made a whole schedule. So I can only, as she said, it's frustrating for me. I can only imagine how frustrating it is for our elders.
The physical fitness, being frustrated by not being able to do what they used to do, and then the resources available, that you have such diversity. You can have 60-year-olds who are up and moving and able to go to the gym, and then you have 60-year-olds who are also using rollators and canes. It's so different. And then the limited resources to get there. Like Silver Sneakers is a great resource for those that can get there, but figuring out other ways to increase that, talk to their doctors or physical and occupational therapists, and bringing the services to them, finding people that will go to their home to provide that is helpful as well.
Economic stability and support is it's tough right now. I just read an article over the weekend from C-SPAN that the rise in poverty in our elders is only growing. And obviously that makes it harder to meet just the standards of living.
We're seeing a large increase in shared living spaces, which are still pretty expensive. And then it again opens a space for the potential for exploitation because they're relying on other people to meet their needs. With that last point in education, tailoring education that is able to be understood by the person who needs to be educated is important. And if us as educators, it's important to be aware of who your audience is and whether they're receiving the information. So any way that we can make like check-ins with them to make sure that they're understanding it as we progress, and being humble enough to recognize when the approach needs to be changed or altered is helpful. Sometimes even the rate at which I speak is something that I have to be mindful of because they don't process as fast. So I have to slow it down and use lesser words to convey my meaning. Next slide.
I think that falls right into the next slide, Bri. Approach for discussions and screenings. You know, as she said, your interview style, it really depends on who you're talking to. We want to remain respectful, relational, and non-judgmental.
Also ensuring they understand confidentiality and the trust and rapport. Usually it takes us 3 visits, and we'll talk about our structure here in a little bit, but before they're willing to open up and speak to us. And then we work as a team. So explaining to them on the front end where the limits of confidentiality are is helpful.
We want to make sure our questions are clear and relevant to their defined goals.
And we never make false promises with that. So we're never going to walk in and tell them things are going to be okay if they're not going to be. We're going to be real, honest, empathetic, and present with it. And the questions are direct and aimed for objectivity. Next slide.
We really focus on the person. So we look at their needs. We convey what their goals should be, truly, without this grandeur, what they used to be able to do, right? Mm-hmm. We want to make sure that we keep their personal preferences in check.
They're involved in their goal setting. So we don't walk in and tell them what their goals are. They're involved with developing their plans, and we make it achievable. So we don't set more than 2. We prioritize, and then we break the goals down into action steps with dates and figure out, are we working towards that or not? And if it's a constant state of crisis, sometimes the goals have to be put on hold until we can establish some calm and then go again. So recognizing their preferences, their values, the different perspectives that they bring, what social supports are there, and then any desired outcomes. Oftentimes, seniors will be your best teachers, and they will tell you over and over again, particularly when we're in their house, that people come in and they talk at them and they forget that they're people. They didn't just stop being that when they aged. Now they're just aged people. So their experience is taking into account and help them drive the bus. We just help navigate. Next slide, please.
The age responsive services, we want to make sure that we're supportive and respectful. Obviously, we have to be flexible with their time. Some like to get up early in the morning, some do not.
With that, the sensitivity to different gender differences, we respond out in a team, and recognizing that I may not be the best person to deliver whatever needs to be said is also helpful, because there are others that look different than me on the team. So that might be something we have to approach.
We want to be sensitive to the person's level of physical and cognitive functioning, so we meet them where they are.
And holistic and thorough, we try to be open to see things around, not just the person that's in front of us, because sometimes the things that are being said may not necessarily match what you're seeing elsewhere. So figuring out if they're processing it and they understand versus if they don't.
Focused on helping people develop and improve coping and social skills. At the end of the day, we are truly offering a hand up and not a hand out. We want to get people back on their feet, no pun intended, but that is the goal. We want them to wake up with purpose and feeling good about the day in front of them.
Next slide. The collaborative relationships has been very helpful in keeping people engaged and retaining them. We operate in a way of intake, keeping them for 12 weeks, setting our goals and processing and making sure that we're meeting the goal. If we have to re-enroll them, we will, but usually we get them to the point of graduation while also respecting their culture. So oftentimes, this is the time when we have those hard conversations. We have the hard conversations when we have to reach out to children or siblings and talk about independence and what we're going to do next.
So a culture of respect, again, meeting the person where they are, and then offering proven services.
And then with the consideration based on demographics, it's a lot easier to access things when we're inside the city than when we're in the county, and recognizing that and being open and upfront has been really helpful. Next, we're going to have a poll question.
So this part is very important because DCF is making this a requirement. And then also we're going to talk a little bit more further on in our discussion on how we are related to our mobile response team here in Marion County. But we definitely need you all to respond to this poll, whether or not you are part of an MRT. And we're going to take 5-10 minute break.
Yep.
Let's take a 10-minute break while we do this poll and give everybody a chance to use the restroom, grab a refill on your coffee, and then we're going to really dive into Marion Senior Services and how we operate our senior crisis mobile response team.
So we'll see you at 10:45.
We're not frozen. We're going to restart at 10:45. Give everybody a few more minutes. Hey guys, you guys aren't frozen. We're going to start. We can go ahead and get started. Robert, if you can go to the next slide. So we're going to really dive into our agency, speaking specifically on what we've done over the last couple of years, and we're hoping that we have some dialogue from you all. So if you have questions, please feel free to throw them in the chat. If they're specific to what we are talking about at the time, then Robert will give everybody a heads up. We'll discuss it. If not, then we're going to address some of your questions at the end. But as I shared earlier, Marion Senior Services is the lead agency in Marion County for Elder Affairs, and we're also the Community Transportation Coordinator. We've been doing this for over 50 years, supporting the elderly, the disadvantaged, and disabled residents with dignity, respect, compassion to maintain their independent living status. Next slide. Our why. Marion Senior Services and our partnering agencies identified and brought awareness to a population who was otherwise unseen. Briana kind of alluded to that earlier. We saw a need for a more unified and dignified approach. I know for me, we work very closely with DCF. We love our adult protective service partners. But this one instance, it was a Friday afternoon at 5:30. An elderly couple's power was being shut off because their house was deemed unlivable. Between Ocala Fire Rescue, myself, and the sheriff's office, we were trying to have a dignified approach. And all I could think about was my grandparents on the side of a road, scared to death, losing their home, has nowhere to go. And that was kind of my breaking point when we all kind of collectively said, this is it, we need to find a better way.
So we started within Marion Senior Services. We have transportation, we have meals, and in-home support. In-home support is where the magic really happens. Well, now we also have crisis. So we started with caregiver support and counseling, and we've morphed into needing that and also a crisis response, which allowed for the advocacy for the individuals and their families, and also help bridge the gap between the siloed services. We have also been able to recognize the more complex situations and figure out who's best to address that particular need. And if something doesn't work, we keep going to figure out what will. Next slide.
So in 2020, we really dove into our community health improvement plan. Every county has this. The report confirmed the understanding that mental health and the physical health are equally important when addressing an individual's overall health and quality of life.
It also identified different gaps in services to seniors whose mental health needs weren't being met through the current service models and helped start conversations for how to meet those needs.
Next slide. And then the one that kind of really hit home for us, and I think you all can probably relate to this, is our residents were seeking care and still seek care for mental health problems in our emergency rooms at higher rates than for the rest of the state.
So fun fact, Marion County is #1 for fall-related deaths in the state. If you go to the next slide, we'll talk a little bit about data. I love data because what can be collected and measured can be improved.
So the data we collected were from our Ocala Police Department and the Sheriff's Office from 2019 to the present. It has illustrated seniors 16 and above being victim of crime, arrested for what appears to be age-related situations, inappropriate Baker Act or Marchman Acts in reference to age-related situations, usually dementia, and or inappropriate use of emergency room departments for routine primary care, mental health, or dental care.
Next slide. So what we've done is figure out ways to identify these individuals and try to mitigate the crisis as best as possible. And that has resulted in a faster, more unified approach that ends up being pretty cost effective. And it's saving man hours also has the positive for morale. Law enforcement and other first responders are able to get back to doing what they were doing before because we're getting systems in place. So the identification of the high utilizers of services have allowed this formulated and coordinated continuum of care.
Next slide, please. So we're going to go over a couple mutual benefits, and you can see some of our partners on there. The diversion from jail or Baker Acts, making sure that our policies and procedures are ensuring what is best for our elder. One of the partners that isn't on there is SMA and our connection with them for our mobile response team certification.
We looked in the first year, I don't think that we addressed it anywhere later. If we do, we'll just hear it twice. We touched the top 15 highest utilizers of all 911, emergency rooms, hospitals, jail, and triaging those 15 high utilizers in 1 year saved $72,000. Next, go
ahead. Next slide, please. Like I said, we reduced the jail and hospital admissions and readmissions, again, reducing the costs incurred for those emergency departments, law enforcement partners, and fire rescue.
We developed the coordinated body of the high utilizer program. So for tracking purposes, we keep track of the focal issue that's being presented, and then we kind of break them into different groups. So we have the high utilizers of services. That can be anybody who frequents the jail, the hospital, 911, our services. It can also be chronic disease. And then we have the core, which is the substance use platform.
We've also included our policymakers and operational levels. We want the boots on the ground to be a part of what we are doing. And that goes all the way up to the policymakers. So we make sure that all our legislative delegates absolutely know of the work that's being done and how they can help support us moving forward.
So weekly we staff in a room. Usually everybody brings 1 to 2 people, and we come out with actionable items, and everyone has something to do before the next meeting to see if we're moving the next slide.
Next slide, please. So as Bri was saying, every week they either meet in person or through Zoom to keep that open communication, have the triage and the treatment plans, and review the data collection and the evaluation of each case across and between our first responders, our mental health providers, our emergency departments, and our in-home support providers. When that happened, we realized that a lot of us were utilizing a lot of manpower and resources for the same individuals. And when we started talking across the board, we started seeing the reduction in costs because we were coordinating the resources across the systems and agencies, creating that collaborative, I can't even say it, too much coffee. We can replicate the model.
The cool thing about this model is that you have the ability to see which piece of it should be used at which particular time. It's not going to be a one size fits all. What works well for us here can change day to day, and it may not be the best approach in your particular area, but parts of it can be. Having the space to have real conversations and really identify what's working, what's not working, and what can we do to change or better the situation, while also remembering that they're people we're dealing with and not just a frustration of an increase in 911 calls. Next slide.
So when you look at our team, in the very beginning, we started as a co-responder, and it really wasn't a true co-responder model because both myself and Sheriff Woods didn't want to send a civilian out to a situation without it being de-escalated. So our folks went out after the fact with their crisis intervention specialist. And in the first year alone, we saw a 54% decrease in the high utilizers of the sheriff's office. Within, I think, a year and a half, we started intertwining our other first responders, which is Ocala Fire and Marion County Fire.
We also have the hospice providers that come and help, the Marion County Sex Assault Center, SMAs at the table, the Vines, Meridian. There's over 20 different agencies that come together depending on what we're triaging. The public guardian system.
Obviously, with the designation of being the lead agency, placement is a huge issue. And an opportunity for us because there aren't a lot of places where we can take these folks, but we know that the emergency room isn't always the best option. So having access to multiple different resources has allowed us to spread that across the table.
It's also allowed the trial and functionality of figuring out how to educate and learn what their challenges are also, because we have multiple different emergency rooms. Sometimes one may be more familiar with an individual than another, and breaking down the silos and allowing for the communication piece of it has broken down barriers and allowed the individual to receive better service.
Next slide, please.
These numbers were astounding to me. 60% of people with dementia will wander. This county is huge. We have a lot of forest here.
A lot of water.
A lot of water. It's definitely been insightful to see the additional challenges that come with the rural community, particularly as it relates to cell service or watches for tracking.
24% of our patients with dementia will have at least one act of physical violence.
That's also resulted in some unnecessary or necessary at the time arrest for stabilization, but it creates an additional challenge we didn't really see coming, which was the further placement in skilled nursing facilities or settings, because now they have charges.
20% of home caregivers experience aggression or violence. Unfortunately, we see a lot of that on the rise during the holiday season, and trying to get in front of that and making sure that our caregivers are well supported and don't feel alone.
And the 60% of homes where a person with dementia lives and has firearms, I think that's a low number. The majority of the homes that we encounter will have something. Just last week, we were in a home and there was a grenade in the curio cabinet. It's just being mindful of what's around at the time. It was not
That's the first time I heard that.
it wasn't a live grenade, but
Okay.
have that moment. The point is, pay attention to your surroundings, because the chance of them having a firearm or other weapon versus not, it's higher.
Next slide, please. So some of the major cases that we see are wandering. They want to go, right? They want to go. They want to go to the store. They want to see their friends, and they are off on their missions.
Sometimes they're leaving from assisted livings and they are very fast and able to cover a lot of space in a short amount of time. They're very resourceful when they want to be resourceful. Hoarding is another challenge we see. This creates a issue for first responders, but also it creates a fire hazard to get them in or get them out of a home.
Sundowning is a huge component. Again, that goes hand in hand with wandering.
And then the catastrophic reactions, everything is the end of the world. And so that window of tolerance is shrinking and we don't have the resources in place to mitigate them. Usually we see this increase on a Friday at 4 p.m. So, Monday when we come back, it's escalated a lot.
Delusions and false beliefs that comes with cognitive impairment. People are in their roofs. They have people watching them in cameras. People are watching them outside when in reality, they're just seeing the reflection, of themselves in the windows.
And then the hallucinating and seeing different things. Before, I've done mental health in a lot of different realms, but before doing this, I didn't know what I didn't know. And seeing their senses, seeing it through their eyes has been very eye-opening. If anyone has the opportunity to do a virtual dementia tour, absolutely encourage it. We'll talk a little bit later, but one of the examples, we had a woman that ran her car into her house. And as silly as it sounds to say it this way, we're thankful she ran the car into the house because that let us go into her house. And what we found once we got into the house was a very different situation. We saw she had wrapped her light fixture with material and duct tape. So again, causing a fire hazard. She had disconnected all of her smoke alarms and put these little wing nuts and electrical tape on there. She had insulation up on her walls, put holes in the walls above, which had nicked some of the wires. I'm thankful we were able to find her when she had just damaged the outside of the house and not when there was a house fire and her inside the house.
So Briana, we have in the chat, please share more about sundowning.
So often you'll see an increase in behaviors as it gets later in the day. That's not always all or nothing though. Depending on the individual that's experiencing the increase in their behavior, it may be different times a day. Usually it's about 3 to 4 is when we see the peak happening up into the later hours, but they'll be up and moving and just like a motor that can't stop. You want to add anything to that part?
They're just more active at night. They become night owls. We were dealing with a woman who we didn't think had any issues, but then I looked at my phone the next morning and I had missed 4 phone calls from her at midnight and she couldn't remember who called her earlier. So again, sundowning is exactly kind of that. When the sun goes down, they perk up and become more alert. And that's when a lot of the issues, I don't want to say come to light, that no pun intended, but.
And to address this other comment about the hoarding, that is absolutely correct. Like, it is expensive to deal with. It's an anxiety disorder. So the fear of letting go of things can be a real struggle. One of the biggest hangups that we've had were when we deal with crisis on a regular, and it's not for it to be less emotion provoking than others, but someone who's never seen a hoarding house wants to fix it quickly, and you can't in that situation. it'll set them on a whole tailspin often. And a lot of times OCD goes hand in hand with hoarding. So it's that anxiety of letting it go. And there's really, as they're losing control of things, you see them hold on more and more to material items. That can be a real struggle because it's important to them.
Next slide, please. So emergency response challenges, when we first started this initiative, the conversation truly started in one of our board retreats. At the time, we had Sheriff Woods with the Sheriff's Department, and we also had Chief McQuaig from the Denellen Police Department. And we were talking about adult protective services and how we could be more proactive and efficient in our approach. And both of those gentlemen really spoke to their challenges as law enforcement. They are first responders. They are not social workers. And the majority of their calls for the elderly has risen to be more social. So we were trying to figure out how to close those gaps and meet those challenges. So for all our first responders, some of the challenges that they see, the inability to follow or understand simple requests of what is being kind of shared or said to the folks that they are responding to.
Also, higher functioning individuals tend to be higher functioning individuals with brain change. So when they're interacting, the difficulty interacting appropriately with others, there's nothing physical, not all the time, that says, hey, this person is having a processing issue. So they may not know when they're first approaching how to best interact or even how to approach them.
Wandering with a dazed or lost like appearance. Again, the sundowning and the wandering. They don't know where they're going, but they're going somewhere.
And then not being dressed appropriately for the weather. We see a lot of, we just had an instance a few months ago where an individual, our RN, happened to be in the neighborhood and pulled in, and she was dressed in winter clothes in the middle of the summer here, lost in trying to get into her house. When they got back to her home, she didn't know it was she, but she had broken all of the knobs and was not able to get into the house.
Next slide, please. Being out of place in a particular situation, hiking after dark. I go back to our young lady in Ocklawaha who desperately wanted to get back to Cuba and would walk multiple miles a day because she wanted to go home. For her being in Ocklawaha, if you're familiar with Florida, there's a ton of lakes in Ocklawaha. So finding her was paramount for us.
And then finding family members to create the supportive environment. By the time they reach our radar, sometimes they've already burnt bridges. And we know what we know because this is what we do every day. A family member may not know how to approach, or even that there needs to be education on that particular point. There's so much diversity in what they see. Sometimes it can just be that feeling that everyone's out to get me and everyone's taking my money, so they stop talking to their family members. Well, at the point when you're trying to educate family to get back involved, not a lot are willing to do that.
Next slide. So specific to law enforcement, exhibiting erratic driving or breaking general rules of the road, they're all over the place.
And they're resourceful. So a lot of times with the new cars, they have things that someone may not have been used to, key fobs. So we had a situation where someone was buying, there's probably still cars all over this county that we don't know where they're at, but they would buy more cars, and car dealerships, depending on how the person presented, they may not know that there's any cognitive change or something to be aware of, because capacity is fluid. If they went earlier in the day to get a car, they may have been completely with it and able to do that. Meanwhile, later in the afternoon, they may have parked their vehicle at a hospital and forgot where they parked it. The next point of the 911 calls regarding missing items, people breaking in, or the hallucinations. Jenny was talking earlier about seeing their reflection in the mirror. That person doesn't look like they used to look, so they don't recognize it's them.
Shoplifting accusation, stealing from local businesses, but believing they paid for an item, or that item is already theirs. We had a gentleman, was it Waffle House or IHOP? He went in and truly believed that he paid and went to leave and realized he didn't have his wallet, and law enforcement was called in, and then we were called in because they realized something else was going on with the situation.
To address your question about the age brackets where seniors suffering from memory loss, there really isn't one. Like before I did this, I thought that the older a person got, the more we would see that. And that's not the case. There's over 100 different kinds of dementia. Anybody who just has time and wants to listen, there's a person, you can find her on the internet. Her name is Tifa Snow, but she talks about the positive approach to care, and she breaks it down into gemstones and what you see. I didn't know that there were so many different types of dementia and cognitive change, but I've seen brain change as young as early 50s, and I've seen people in their 90s that have it completely together. A lot of times what we see may look not like on the surface as not an issue. We have someone who calls an alarm all the time, and I was completely convinced that there was an alarm going off in her house until I went to her house and there were no alarms in her house. But she calls multiple times a week about the same hallucination. Well, speaking with her, please spell the name, Teepa, T like Tom, Eep like Papa, A, and Snow like
Snow
outside. So with her and her delusion of the audible alarm, talking to her children, we were able to find that she was previously a nurse. So she's hearing the alarms, like what would be on monitors. And we tested that theory out by playing the sound, and it was in fact the exact sound that she was hearing. So it took us about 6 months to figure that out.
Next slide, please. We touched on this before. Again, specific to our law enforcement, domestic violence or physical abuse turns out to be a situation with the caregiver or the individual having the brain change.
And with that, there really aren't, so it's intent, right? So we've had situations where the aggressor is the one that we need to figure out how to stabilize. So jail is not the best fit for that person, but we don't really have a system in place. So what we found that's been working, that takes a lot of moving parts, is getting and building primary care physicians or connecting with their primary care physician. So we're able to get the forms filled out to put them in memory care for a few days and let the family hold and get systems in place, or have a conversation with the family that says it's okay for you to love them and keep them safe in that particular environment. We were able in one instance to have a conversation with a very young officer who had previously let the man walk through the house. The man had choked his wife, but the way in which he choked her wasn't how one would. So in just asking some questions, we found out that he was previous military, he was previous law enforcement, but the young officer that was on scene never asked questions about guns. So when I was having the conversation with him, he was like, oh, he doesn't have any guns. Just do me a favor and go check, because he's going to come home in a couple days. They found 4 guns, and he had been walking all over his house the whole time that they were there. Next slide, please.
So specific challenges for fire rescue, assessing symptoms amid confusion.
I love the term altered mental status, and I really like it when it has conversations start with, are we going to transport someone for altered mental status or not? And then that goes with the opportunity to go to the hospitals and start the conversations. One thing that is really important in any kind of system like this is grit, determination, and resilience, because not everybody is going to be on board with your want to change the world. And having that tough skin and recognizing the why and going back to the why for advocating for people is so important.
So managing safety for self, patient, and others while providing reassurance. Our team never goes out alone.
And while we're in the home, one person has roaming eyes while the other person's interacting. And if there's more than one person that we're interacting with, usually we'll separate the caregiver from their person. I really love it when they have sunrooms, because then one person can be out there and the caregiver can have a break, but they can still see their person through the door, so they know that they're safe.
This last one's pretty important, not removing patient from familiar surroundings unless necessary. This is a trigger, right? When we remove them from their familiar settings, unfortunately, we have seen a spiral. So we only remove them unless it's absolutely necessary for safety.
Next slide, please. And recognizing the social service or mental health needs is really important. Like we were talking earlier, to know which one of us was going to speak or engage at that particular time. Usually when we're out and about, there's two of us. We try to be diverse in appearance, because sometimes me saying it out of my mouth is not going to get across. But if Captain Hickman or Captain Blair or Lieutenant Edwards says it, they'll hear it better from the fire department. It just depends on who should take the lead at that particular time and address the behavioral aspect of it. When that isn't working, somebody has to take the ball and decide, are we filing for next parte or filing for guardianship? But that process is long.
Hospitals are a huge part of our consideration. We all have heard hospitals are for folks that are truly sick, and we don't want to take someone to the hospital just because there's nowhere else to take them. So we truly try to engage our hospitals and divert them from the emergency room or an active hospital bed to ensure that someone else who truly needs that bed gets it.
That's awesome that in Citrus County, they trained all law enforcement officers on de-escalation. That is so important. Love it. And absolutely, yes, changing the environment you'll see a fast decline for sure. Next slide, please. Knowing to adjust our approach can increase the likelihood of a more positive outcome for all. So this is that one piece that we talked about in how we know who should be speaking or approaching, or the words that are being used. And sometimes speaking on the fly is really helpful. We carry peace offerings, and sometimes animal food is the way that gets us into the house a lot. I think we've probably had more animals in our cars than
she wants to tell me about.
Yeah. But I mean, sometimes if someone is not going to go to the hospital until they know that their dog or cat is safe, and if we can just meet that need, then that's what we do. That's their family. So recognizing and knowing that. And also, we each take turns being support for each other, because this is an emotionally inherent stressful job, right? So there's going to be good days and there's going to be bad days, and recognizing when, hey, you're not the person that needs to go approach it is really helpful. I don't mind dogs, cats, whatever, but I have other teammates that do mind. So when we got sent out and there was a monkey while it was raining and we had to go through grass that was chest deep, I knew I was taking the lead on that. Now, after the fact, we all came home and were like, yeah, we really did that. We were in there with the monkey, but we all survived. Next slide, please.
So, best practices. Again, we lovingly say that we are building this airplane in flight, and we truly have. If we add a part and it's not working or we need to adjust it, we do. And it's been 5 years going back and forth, but these remain to be pretty true. Identifying our stakeholders and any duplication of services. Bring in the right people to the table. And our first responders were definitely the right people to bring to the table because they are usually the first ones that can identify and touch those that are in crisis.
And then deciding who's the lead and how to develop and coordinate the body has been really helpful as well, because sometimes they're not able to apply for the ex parte or fill it out, and they can't say things that I can, and vice versa. So it's been very helpful to know who's taking what, and even their physical appearance. The paramedics often wear gray; they don't have shiny stuff on them, so you may see a better response in the gray shirt and no shiny things versus law enforcement who has things on them.
Open communication, documentation, and feedback. Again, we meet on a weekly basis. Open dialogue between all of our agencies is a huge part of our success, and it has to be honest, open dialogue. If we did something that wasn't right, we need to go back and we fix it. If we took the wrong approach with someone, really triaging each case with that open and honest dialogue is huge.
And recognizing where the limits are, because there will always be more needs than resources. So sometimes we can't meet the need. This next point, identifying the public guardians, private guardians, this is an area that's an opportunity for a lot of growth.
And I think it's not just Marion County. I think this is across our state. We have identified POA issues. And then, it's much easier to become a POA versus a guardian. We just met with our clerk of court. We talk religiously with our state attorney's office and trying to make sure that the right people have the right reasons in play.
So to address the HIPAA issues and the collaboration, when someone has the ability to consent, then they sign release of information, usually within the first visit. So we are able to have them sign the release to let them know that we will be discussing and triaging as a team.
Reduction in 911 and duplication of services and allowing individuals to age in place safely and with dignity. I think we've shared that throughout our presentation, and in the next couple of slides, we're going to give you some case studies that really show that in action.
We don't take the place of 911, well-being check, or DCF calls. This is still one that we are going over. Mandatory reports. If they see something, say something. It's not their job to do the investigation. The reporter, I'm saying, if they see something, say something. Make the report to DCF. It can be online. It can be over the phone. And then observations are important. What someone says may not necessarily be what the person is seeing. So training yourself to see around you is very important.
How many bills are on the table? What's being paid? What's not being paid? Who's coming to the house? Who has keys to the house?
Dents on the car.
Dents on the car. Just really, as Bryce said, have your head on a swivel and not just stick to the common assessment questions, but really look around their environment and make observations in what's normal and what's not.
Next slide. I am very proud of this team. The first picture is Marion County Sheriff's Office, Ocala Police Department, SMA's Mobile Response Team, Senior Intervention Specialist, Marion Senior Services Team present. The second picture, that's the same day. That's me and one of the crisis intervention specialists. And the third picture is all of her belongings. She sold her house on Telegram and moved multiple counties away to this motel with not the best individuals in it. She was a target. She had a previous TBI and she believed that she was in a relationship with a celebrity. And she was still engaging with said celebrity via Telegram. So in backtracking, what we were able to find was that they were using AI to generate a face. And so it didn't matter what we were saying. She was believing wholeheartedly in this, and she wasn't giving us any information, not even her real last name. She signed in as her first name and the celebrity's last name. So even in the approach, like you can see at this particular time when we were speaking to her, she was making most connection with the two paramedics, and they physically like dropped themselves to her level. So one's on his knee over there and one's sitting in the chair next to her. So they were eye level and not above her. She had been a little bit amped up. So the deputy is still close enough that if something were to happen, he was still there to like intervene. And then all of us were back far enough away to just give space and have the conversation. And then as information was being shared, we were able to step away. We did find her son, and the son was able to pay for her to stay there until he was able to come down. She wasn't happy about being taken back to where she came from, but she was safe, and we helped get systems in place. How do interactions in a person's...
Hang on. We're reading the chat. Hang on.
So a lot of times when we have a healthcare surrogate that's willing to be involved with us, it's great because we're able to provide support to them and also affirm or reaffirm that it's when it's time for them to use those papers. Sometimes that's the hardest thing to recognize, when it's time for me to step in and do the medical surrogate things. We try to get everybody the file of life and teach them how to have their DNRs on file or their paperwork, their power of attorneys on hand, and we get them to put them in a red or a yellow folder by their refrigerator, so that way first responders know where to look. And then if there's no information about who to contact, that's really where we struggle in getting with DCF to see if they can find anything. DCF comes to our meetings on Wednesdays, and we're able to kind of backtrack to see who's where. We're still working on better systems for that, but for the most part, when we can provide support for them, and it's very rare that we have someone who already has a surrogate in place, but we try to educate others to get them in place before they need them. Good question.
Next slide, please.
Okay, so that's some more pictures from another day when we were out there with that individual. As you can see from the bottom picture, that was again a multi-agency response. On this day, though, she had caught her shirt on the pilot light and almost blew up the whole building. So we were able to recognize that we needed to do something, get with management and get the gas shut off. The first picture, though, is a very important dog. So he was one of our high utilizers dogs. We didn't know that his heart failure had increased to the point where we were, but we were able to have an amazing Dr. Lasada. She's Wonder Woman.
Mm-hmm.
We got this dog and this man into the hospice house, so he had a dignified approach for end of life. And when he passed away, the social worker adopted this dog, and now the dog is used in a lot of things. He earns his keep on a regular, best dog around.
Does making so many people there ever make it worse? Some people don't like so many people.
Sometimes, so we don't always go in. That's a very unusual response. Most of the time it's only two of us. And sometimes if there has to be multiple people, we step out and only whoever needs to interact. We never are in there by ourselves. So there will always be two of us. And even when they want to separate the two, we just let them know, like, no, they will always see us. Most of the time, if someone's escalated, well, I can't even say that. It depends on who they're making the connection with the best for who's going to talk. And then again, being aware of your surroundings to know what's happening in other places if you need a quick escape out.
How many people have those kind of arrangements in place? I'm assuming she's still talking about the healthcare surrogate.
Yep.
Do we have that data?
Not very many. I really, really wish that there was more education and ability to have those in place. Like I've seen some some communities do like fun events. They'll call it like death over dinner, and they'll educate and create the folders. You can get like peace of mind planners or end of life planners so they can write the things out. I like that they can have the stuff in place, but it's really important to educate them also to protect themselves, because sometimes people can pretend they're helping and that information can get into the wrong hands. What I've also seen that's been helpful, if they own their home, for them to record the stuff and have it attached onto their house, like in public records, so it's able to be pulled up. We've also found with that fraudulent power of attorneys, though, and things of that nature. So it just kind of depends. We've had houses be taken from people, and our deputies have actually been able to help and advocate. We got 2 arrests last year for that.
Next slide, please.
Good questions. We would be remiss to not talk about our client Zero.
She was our first one.
She was. She lived life on her own terms. Every time I have a frustrating day, I have to remember, like, she frequented the jail, the hospitals, Baker Act facilities, 911. One of my favorite memories of all time was when she was throwing French fries at my partner as we were walking down the sidewalk. But I do not feel like we could have done things better. Like, I need to say it that way. We could have done things better. But the biggest thing with this, she had children, she had siblings, she owned her house, she had resources. When her memorial service happened, our teams were the only ones present. So at that moment in time, it reminded me, like, if we didn't take a moment to remember her presence, she would have been completely forgotten.
I think for me, with this particular case, it was how broken our system is. And when we all started talking, everyone's head kind of blew up, because everybody was just so, I don't want to say frustrated, but everyone was trying to help this woman who did not want our help, but she was being misdiagnosed, misunderstood, and again, putting herself in vulnerable positions, being arrested when she shouldn't have been there. And it was just because of those key things, being misunderstood, misdiagnosed, and we never gave up on her until the very end.
Yep. Next slide. This one was wild. Where this house was located, it overlapped with the city and the county. So actually everyone ended up responding. When we got there, she was literally signing, at that very moment, she was signing a deed. There was a mobile notary and a realtor on scene. We were able to stop that then, but we found out that one of her homes had been taken and sold already. While we were all in this first visit, 2 people show up driving very expensive vehicles and presenting power of attorney paperwork. We were able to do research. So at that point, we're aware of things. She was only eating Reese's and drinking Diet Coke. We were able to find a sister, and they were able to get a financial injunction in place. This is the one where they ended up arresting people. During the civil situation, basically the suspects brought all of the necessary paperwork that was needed for the arrest. So basically
it was awesome.
They
did our work.
Yep. So now she's still home. She has caregivers that are there every day, and she doesn't just eat Reese's and Diet Coke. She gets meals. She looks great. They take her shopping. Her and her little dog are doing amazing things.
Next slide, please.
This one, her caregiver was exploiting her. They lived in a mobile home community. He ended up passing away. Then the neighbor who he was having a relationship with was coming into her house and harassing her. So we saw an increase in 911 calls. We saw an increase in anxiety. but we didn't know what was provoking it. We didn't know the why because she couldn't remember what was happening. She had support with AA, but there was still time that was taking place to get the guardianship after she had been deemed to lack capacity, until we got there one day and she was putting laundry detergent on herself as lotion, and she had put the laundry detergent in the refrigerator. So at that point, we were able to get her to the hospital, and from the hospital, we were able to get a form filled out to get her to a temporary placement until DCF was able to get guardianship of her.
Next slide, please.
This one was one of our first also. She had an extensive history with mental health. She became isolated and secluded, and even like in how she barricaded herself in, she physically moved trash cans in front of her house, and there were always people in her attic that were coming to get her. But when her Social Security hit, the scammers would send her to Publix to get green dot cards, and then they would have her send the numbers. She thought she was paying her attorney, and she ended up losing her house.
Yeah, so when we spoke to the attorney, we asked him which office he worked for, and he said the Florida bar. But we were able to get her taken care of and secure her financials, even though by the time we were able to do that, most of them were gone. And again, I believe at her memorial, we were the only ones there. We were the only ones.
When we talk about high utilizers of 911, sometimes it can be 7 calls in 2 weeks. In this particular instance, it was 269 times in a 3-month period of time. So she was calling multiple times a day at all hours of the day. And it was just a situation where it really was necessary for someone to speak up for her. Next slide, please. This one was wild.
You say that for everyone.
I know. She was not nice. She did not want us there. But she had a nest. She created like a nest, and there was boxes everywhere. She too was a high utilizer. She had actually called more times than the previous one. But we were able to finally get a hold of her brother, who actually lived in this community, and her brother was able to help us get her to a hospice house and safe and not a fire hazard.
So yes, these cases are heart-wrenching because they are so vulnerable. We had a great presentation by Shannon Miller. She's an elder attorney out of Gainesville, who really allowed us to understand, and she's done her research as well in regards to the brain. And one of the things that she said, before someone's diagnosed with dementia, there's several years prior to that where they're vulnerable and they believe things that they normally wouldn't. So we are constantly educating ourselves. Like I said, we're building this in flight. But next slide, please. So this is the exciting part, and this is where I get excited because you have the option to replicate, and not every community is going to be the same. Marion County is not going to look the same as someone in the Panhandle or South Florida. However, the nuts and bolts that we used, you absolutely have that within your community. So like I said before, every community has a needs assessment, and the beauty of the needs assessment is becoming involved and having your voice heard, because once it's published, you have more opportunities to garner, finding those stakeholders and then also applying for grant opportunities.
And especially when you have the naysayers, I think it presents another opportunity because you're able to prove yourself. So when we first started finding those 15 high utilizers, that may not be your number. Your number may be 5. And seeing what you can do with those particular identified individuals, that gives you data to prove yourself. And once it's proven, then you can expand on and keep going.
So also with the needs assessment, you can identify the services that you will provide. Where we started it's vastly different from where we are now. Where we started was identifying the high utilizers within law enforcement. And now we're talking to the clerk of court regarding guardianship and power of attorney. It's like an onion that you're peeling back, and with every layer you cry a little bit because you got to dig in.
And figuring out who is in your community, what services they provide, and how to get them at the table. Those symbiotic relationships really are helpful, because what we're good at, somebody else may not be good at, and vice versa. And sharing, and it's better for the person we're serving. That is so true about what could be a delusion, but is in fact a practice flight for sure. And the challenge, hearing with your mom with dementia, yes, reach out, get you your support system, because you can't pour from an empty cup. Absolutely.
Define how services can be used and ensure they're accessible. That really, again, works when you get your stakeholders at the table, and again, having that open dialogue about what you can or cannot do.
And recognizing for you what you can and can't do. I want to save all the world in one day, and sometimes I have to pump my brakes and recognize we can't do that.
Develop relationships with community service providers and stakeholders. When you go and you meet with those individuals, you really need to present a win-win, and why it's beneficial for them to participate within the program. Like I said, with the sheriff's office, it was easy for us because, the sheriff was already saying that, his deputies are not social workers. And we were offering him a resource to alleviate that burden. Same thing with the fire rescue. And again, every layer that we've brought back, we've brought a win-win situation to everybody.
So in telling your story, it's important that you have the numbers and the data and also the feelings. So it's for the qualitative and quantitative side of it. Yes, we have partners that do pro bono services. It just depends on, that's that area that we have the opportunity for growth, because right now we don't have a way that if someone has assets to kind of trigger the guardianship process coming out, we're still working through that. But each one, those high utilizer meetings is where it's really been helpful to see what resources are available there. And then the services are initiated. This is where we grew too fast, too quick. And we can recognize and say, we started with getting the referrals from law enforcement and fire rescue, and we were able to manage that. Sometimes that was assessing them and waitlisting them for elder affairs services. And then the APS services, sometimes they either came in as APSs or we were the ones to call in the APS. So that's two different arms going forward. Now we get the referrals they come from all over. We have expanded the team. In the beginning, it was just me. Within Marion Senior Services, we now have 4 crisis behavioral care coordinators and a human service counselor. And then we're partnered with the county paramedicine team, the city paramedicine team, Marion County Sheriff's Office, and Ocala Police Department. So that has been helpful. The caseloads for us kind of ebb and flow. We try to do a 30, 60, 90 handoff because we don't replicate the services that in-home support does. So our community care arm, they have case managers and assessors also that have, they do an outstanding job. So we kind of identify them, triage them, get services in place for crisis, and then they continue the services there. And then if the crisis rekindles, we try to go put more services there as well. What's that? What's the second part of that top one? Yes, they do. We do re-engage. Sometimes that's with the whole capacity idea and talking back to DCF to see, is it safe for them to be in their home? Do we need to look at other placement opportunities? How are we funded? So we are completely funded through us, Marion Senior Services Crisis Response Team, is funded through Lutheran Services through DCF. The county teams and city teams are funded differently.
Is there any related services in Miami-Dade area that you would recommend? I'm not sure, Lydia, but I can get back to you. In which regard do you like aging services, or what were you looking for? Let's keep going because I don't want to run out of time. Collect feedback and adjust. Again, going back and talking about, building the airplane in flight. Again, having those honest conversations, what's working, what's not working, and then adjusting. And as far as aging, Lydia, I will get back to you on who's the best person within Miami-Dade area.
Debbie, no, but the services that we provide, there is no cost to the individual or the family that we're engaging with. We are funded, us and the fire department are funded separately from there. So they don't ever pay for the crisis services that we're providing. Next slide, please.
Lydia, you could look up your area agency on aging, and then you can find your local service provider that way.
So one of the things we're working on with program funding is the ability to network and get credentials for community health worker, mental health counselors, kind of billing insurance companies, figuring out what HEDIS measures are available and looking to see what would be best for everyone involved. So it's never going to be a one stream way to do it. Right now, we've engaged a lot with complex cardiac issues, chronic disease management, those that are really heavy on the system and also are more costly. And we're figuring out ways to kind of have a shared approach to that.
Staff recruitment and retention. You got to have a heart for what we do, and a stomach for what we do. Some days are a lot easier than others. Some days it's a lot easier to laugh than cry. It's okay to cry too. We've had a couple cases that didn't turn out the way that we had hoped, and we all kind of had to take a break and a breather and then go back at it. So not giving up and just trying to do the best that we can.
And for recruitment, let's be real. This is not the position that you're going to be millionaires at, but you get paid with the heart and recognize that like you're able to think and grow and be. So I am very thankful that I have leadership that I can come with an idea and we try it to see if it works. And then we find a way to make it happen.
Accessibility of services, again, sharing the partnerships, being able to refer them to different referral sources and resources and having them available is pertinent.
And the availability for the training and continuing education, sometimes it's also looking outside what's right in front. So like the area of aging conferences, the co-responder conferences, 911 conferences, law enforcement, fire rescue, different Alzheimer's and other dementia related trainings have been great. Where else? We've been
ComHit.
ComHit, that's a good opportunity. That's down at Kennedy Space Center. There's often free webinars that they log into and share on remote monitoring and having the opportunities to see what other places, if we're similar or different than other places like us. And then limited referral options. So that's for us receiving referrals and for giving referrals places, identifying what's in your community and how best to access it and being realistic on, I don't want to say saturation, but really what you can take on and what you can't.
Next slide, please. So I want to thank Robert because he gave us a lot of great resources. The Elder Fraud Abuse Guide is something that we put together with our state attorney's office and our law enforcement. Education is the key to prevention. Unfortunately, with a lot of these financial exploitation cases, offense is your best defense. So trying to educate as much as possible and not having them feel embarrassed for asking the questions. I mean, these people have become so savvy that, it's not just the elderly that are falling for it. I have friends that are falling for it. So making sure we work with our partners in educating our community.
Audrey, same thing with the home care services in Polk County. If you look up your area of aging, you can start the process on how to get connected and the assessment for the in-home support services that are offered there.
And you can find that on the Florida Department, the DOEA website. They have a whole map of our entire state of our 11 different AAAs and the various service providers. Bri mentioned the Florida Council on Aging. That is a great group of professionals, and I'm even going to throw the Florida Association of Aging Service Providers. Two great resources. Every August, the Florida Council on Aging hosts a conference in Orlando, or at least it's been in Orlando the last couple of years. But again, you are amongst aging providers that has a whole host of different topics of and how to protect our elderly. Obviously, our website's up there.
Mobile response teams, you can also click on there to see where all the mobile response teams are in the state. We are unique in that we focus on seniors. That's what differentiates us, but it also allows for the opportunity to work very closely with SMA's mobile response team. We have more opportunity to see who's the best fit for the particular person. Usually, if it's an age-related situation, we end up with them. If it's someone that's been chronic mental health, SMA's MRT will take the lead on it.
The National Council on Aging is a great resource to see what everyone else is doing across the nation. Every state is set up a little differently, and I think the great thing about our program is nothing's off the table. We're willing to consider anything and everything and kind of morph it and make sure that it fits our community. Next slide.
And then there are some more resources available for specific how to approach older adults. I'm really excited that we're starting to have this conversation, because before they were unseen and just grouped with everyone else. Looking at the specialty treatment team maps, that's also enlightening, and it allows to see what's available and how best, if there's something that's not available and you think it and you have the heart to try it, absolutely. And we're available if you have an idea or want us to come and visit and share and do, we can do that too. Like, we love to share and help, and we're open to learn. So if you have something that you think would make us better, by all means, share that too. It does take a long time to get assessed for the services to be put in place. I was reading about that, but also remember there's the adult protective services. So if you're not able to get things and the need is arising to a crisis situation, don't do it alone. Reach out. There are services that are there's providers that are in place for that. Are there any other questions in the last 9 minutes that we have? Thank you, guys.
Thank you, Jennifer and Briana. I do want to open the floor just for a moment for some questions. I know we had a lot here, especially in this last half. So we have a few minutes before we have to wrap up. If you have any questions, please put them in the chat and let us know.
We just appreciate the opportunity. And you all are more than welcome to come visit us and do a ride along.
We always want to continue to be better than we were yesterday. So our goal is to be 1% better today than we were yesterday. We also had an amazing thing. We just got done with Give for Marion, and special shout out. We now have a vehicle for, I know, but that was too.
We partnered with our Marion County Hospital District. And like Bryce said, Marion County is known for fall deaths, and the hospital district really wants to support and promote a healthier lifestyle. So we were given the opportunity to get a car, and it's going to be supporting our fall prevention programs and making sure that our elderly neighbors have the resources available to them to keep them standing upright, or at least in a stable environment, so we can prevent falls. So yes, big shout out to our hospital district.
Thank you so much, Jennifer and Briana. I'm going to take over and go to the closing items. I do see a question. Cynthia says, where is the full list of those resources available? Cynthia, I am posting the PowerPoint PDF in the chat. So those will be at the end of that PowerPoint. Sandra, I see links do not open. I will follow up with you momentarily. But I'm going to switch over to the closing PowerPoint. If everyone will hang on for just a moment. I want to thank Jennifer and Briana, both of you, for the webinar today. It's always a pleasure to see so much good feedback in the chat and a lot of questions and engagement. And thank you all for sharing your information about our senior population, as well as some of the things you're seeing in your work. So thank you both. When this webinar ends here in just a moment, you should get a pop-up that looks like this picture on the screen. It will say the host or presenter would like to open WebEx meetings, or the host or presenter would like WebEx meetings to open a website on your computer. This is not spam. This is WebEx trying to redirect you automatically to the post-webinar evaluation. So click continue to be automatically redirected to the evaluation. It is also posted again in the chat. To complete the evaluation, you must sign into your FATA account. If this is your first webinar with us and you do not have an account, you can register for one at no cost. You may do so by clicking haven't registered yet underneath the sign in menu. You must use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. This is the only way for us to connect your attendance to your evaluation completion. For CEUs to be reported to CE Broker or Florida Licensed Healthcare Practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the Professional Information section of your profile. You will get a third opportunity to complete the evaluation through a follow-up email later today. As a reminder, the evaluation will close at the end of the day on Friday, September 26, 2025. If you need assistance with logging into your account, registering for an account, or completing the evaluation, please fill out a contact us form on our website or email training@floridabha.org. We do not email statements of credit. Instead, once we have verified your attendance and the completion of the evaluation, a statement of credit will be posted to the professional development section of your profile in your FATA account within 30 business days. You must have attended the entire webinar and completed the evaluation for a statement of credit. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access previous webinar recordings and PowerPoints, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you, everyone, for participating in today's webinar. Thank you again to our presenters, Jennifer and Briana, and thank you to the Florida Department of Children and Families for funding today's webinar. Have a great day, everyone, and please hold for the evaluation.